Hello, I'm Kirsten Matthews. I'm the Baker Institute Fellow for Science and Technology Policy. But the reason I'm actually here too is because I have a strong interest in biomedical research, health, and the global health work that we do at the Baker Institute Center for Health and Biosciences. So today we have a very distinguished panel, and we're going to introduce them one at a time. They're going to give short presentations, about 5-7 minutes or so, and we're going to spend most of our time with question and answers. We have a few for the panel in general, and then also we're hoping from the audience to get your participation in the panel discussion. So we're going to start with our first speaker. I like to refer to as Dr. Lieutenant Colonel Wendy Sammons-Jackson. She is the military deputy to the principal assistant for research and technology at the U.S. Army Medical Research and Material Command. She also has a strong history and has a PhD that's worked with some pathogens related to bioterrorism. And she's going to talk about some of the work she's doing right now for the Army.
Yeah? Yeah, okay. Good morning. First, I'd like to thank our organizing partners for putting this wonderful event together and for the opportunity to include the Department of Defense. Did I get it? The Department of Defense and the Army in this discussion. So I truly appreciate the inclusion in that. So looking out at the audience, I wasn't real sure how to shape this discussion, but it's clear to me that I suspect the audience may not be as aware of what the Army is doing in research and development for medical issues. So I thought I'd kind of put a frame around Army medicine and research and development, and then talk a little bit about how that ties to global health and partnerships, specifically here in Texas. So our focus is on the health, the readiness of the warfighter. So what does that mean? It's a spectrum across the entire life cycle of a soldier when they come in the training environment, in the garrison environment, as they deploy, if they're injured, recovery, and all the way to the handoff to the VA. So we have a very broad portfolio of medical R&D to cover and span that entire space. So, whoops, you have a slide? You can, sure, I can do it. Thank you. I promise I will not try to kill you with PowerPoint, but, but it'll help, I think. Where are we? Did it go? There we go. Okay. So because of the focus of this, I just wanted to put in perspective this discussion in infectious disease particularly. I want to put in perspective really kind of the broad range of our interests and then focus in on infectious diseases. So how do we focus our strategy in research and development for Army medicine? One strategy is we have developed intramural research capacity. So it's across many competencies. Up here on the slide are listed the competencies that we currently are focused on. They shift and change slightly. The last more than a decade of war has really changed our competencies in many different areas, not necessarily infectious diseases per se. And I mention that just to put in perspective prioritization and how our R&D needs to be prioritized. The signature wounds of the previous decade and a half of war were PTSD, traumatic brain injury, and trauma on the battlefield. So infectious diseases didn't necessarily grow. The R&D environment didn't grow in that environment per se. However, we did stay fairly flatline. But I think there's a new trend. Ebola, Zika, emerging infectious disease, MERS, a number of things are kind of bringing the spotlight back onto infectious diseases, and definitely within the DoD. So I mentioned we build capacities. The first two laboratories are Walter Reed Army Institute of Research and the U.S. Army Medical Research Institute of Infectious Diseases are primary intramural laboratories that conduct research in infectious diseases. The Army has the majority of medical R&D within the Department of Defense, so that's why I'll focus this discussion on the Army specifically. We execute the majority of naturally occurring and endemic infectious diseases, as well as the Chem Biodefense program. So we're unique in that our Ebola, for example, fits into our Chem Biodefense program. They're stovepipe, so to speak, and Zika fits into our naturally occurring endemic infectious disease program. But the good news is they're all conducted by Army laboratories. So we're able to leverage each other's capabilities that way. We also have expanded capabilities OCONUS. So we've developed research platforms and capacity in the regions of the world where the naturally occurring diseases are. And it's been a very valuable resource. I can give you an example recently with the Ebola outbreak. We have a very robust program in military HIV research, and there's a number of clinical trials and research laboratory capacity at OCONUS. The Ebola program is a Chem Biodefense program. However, we were able to leverage the capabilities that we had OCONUS in the HIV research program to conduct a number of clinical trials that are ongoing today. So the very first clinical trial was conducted with the Department of Defense laboratories. So what makes the military infectious disease research unique? We're focused on, we own the S&T as well as advanced development responsibilities for R&D. So we're very product focused. Most of our research fits into the applied translational realm, not as much basic science. We depend on NIH and other partners to leverage the basic science and the knowledge gained to translate that into something that is either a knowledge product in terms of clinical practice guidelines or a product that can be delivered to help protect the warfighter. And also, so I mentioned the first part of our strategy is capacity building in our intramural labs. The second part is partnering. We can't do this alone. We're not resourced to take a product from discovery all the way through FDA licensure and into fielding. So we rely very heavily on partners with industry, other federal partners, multinational partnerships as well. So this is just a snapshot of where we have a number of partnerships, either agreements where we currently have capabilities, capacities, and collaborations across the globe. So to bring it back to the focus today on Texas, so we have a long history of close partnership with Texas through the university systems as well as the research institutes. We have a number of, I don't know if anyone's familiar with our long-term health education and training program. It is a DoD-funded program that sends officers to work on a PhD or master's program. And so we have sent a number of our scientists back to the University of Texas system to be trained, and then they come back into our laboratories and become leaders in infectious diseases or Chem Biodefense area. So that's a very critical asset. So for us is to leverage the expertise to solve military problems. I just did a quick span of collaborations focused on infectious diseases in Texas, and we have currently greater than 40 active collaborations across the spectrum in the state of Texas. Of course, everyone's aware of the DoD footprint that we have in Texas with our Army bases as well as our center and training school. So if you're in the Army medical field, you have been to San Antonio at some point in time in your career. It's a very valuable resource. It's where we do training, developer requirements, and combat development for the medical force. occurs. So why? That's sort of the question that I pose. Our problems, the military problems, because we're a population of more than 500,000 people, which is small relative compared to Texas, but we're dispersed globally and continuously. So they're span into regions of endemic diseases that we are, we're fairly a sterile population here in the United States, for the most part, comparatively speaking. But as we go into these regions, we become very vulnerable to the infectious diseases that are endemic in those regions. So military problems are closely linked to global health problems. They're one and the same. And the global health problems can quickly, as you've already seen, and this audience is well aware, can become national state problems very quickly in the blink of an eye. So although we, meaning the DOD, the state of Texas, the local officials, we look at the problem through a slightly different lens. The problem's the same. The intended outcome's the same. We want to protect our population of people, whether it be Texans, whether it be service members. I think we all have the same outcome and are looking for the same solution. So some thoughts that I was generating in my head on how can we do this? And I think that it's a continuing theme. Invest in infrastructure. That is sort of a strategy. That is a strategy that we do within the Department of Defense and our intramural labs. It is not an easy strategy to do, I can tell you. We compete with the other R&D needs of the Department of Defense, which are weapons and tanks and planes. So medical is a very small portfolio in that. So it's very difficult, but we continue to make the argument why we need to invest in infrastructure and capacity. Some other thoughts that came to mind is some of the challenges that we face, in particular in emergent situations, is we're very good at planning. We can plan something to death in the DOD. However, we're not good at responding. We don't have processes in place that are flexible to shift in our focus, in particular our resources, to address emergent needs on a dime. So I'd like to think and maybe trigger some discussion on how do we create flexibility in that? How do we develop the infrastructure, make it flexible to be able to respond, and also to open up for non-traditional partnerships with the DoD. We have numerous partnerships with other federal agencies, international partnerships. What we don't do well is public-private partnerships. So we have started to look at some new creative ways within the authorities, that the constraints that we have, to be able to do some of these new and unique partnerships to try to expand the capacity. And that's all.
Thank you.
Thanks.
So our second panelist is Dr. Leduc. He is the director of the Galveston National Laboratories and the John C. Lee Distinguished University Professor Chair in Tropical and Emerging Virology at the University of Texas Medical Branch. He does a lot of research there. He leads the research on infectious disease and often neglected diseases to develop strategies and interventions for both specific diseases and broad syndromes. Prior to coming to Texas, he also worked at the CDC and a stint at the World Health Organization. So thank you for coming today.
Thank you. Well, first, let me thank the organizers for inviting me to this. This is really a wonderful opportunity to share stories, not only about our resources at Galveston, but also how Texas can lead the nation in responding to emerging infectious diseases, and especially in partnership with the petroleum industry. I think this is an opportunity that hasn't been fully utilized. It's appropriate for me to speak after Colonel Sammons-Jackson, because I'm actually a product of the organization that she spoke about. Just by way of introduction, I graduated back in the dark ages with a bachelor's degree right in the middle of the Vietnam War. So my first job was with the Smithsonian Institution, and I lived in West Africa for 2 years in a tent collecting rats and mice and bats and all the things that we now know are reservoirs for all these diseases that we're concerned about. I then came back and was greeted with my basically draft notice, and they said, you can either come in as an infantryman or you can come in as an officer. Well, I wasn't very bright, but I figured an officer is probably better than an infantryman. So I then went to Fort Sam Houston, as everybody in the medical field does, met my wife there, who was an Army nurse, and began a career that I had no intention of pursuing, but in fact was probably the best decision of my life. I met some of the brightest folks and had wonderful experiences both at Walter Reed and at USAMRIID. And overseas, I ran a laboratory at the mouth of the Amazon in Belém, Brazil. If you want to look for viruses, that's the place to go. I also ran a laboratory in Panama. And so at the end of my military career, I decided that public health was and I was also the beneficiary of graduate training. So they not only gave me great hands-on experience, but they also bought a degree for me, which came in handy. I then went to work for CDC, but my first job at CDC was with the World Health Organization, and I was there at the time when emerging infectious diseases were just being recognized as a real focal issue, and my job was to institutionalize at a global level the same initiative that was taking place at CDC. I was benefited by some natural outbreaks. The Kikwit outbreak of Ebola that occurred in the mid-90s was under my watch, and so we started to build this whole response. And then I came back and I was at CDC until I was recruited here to Texas to run the to participate in the organization of the Galveston National Laboratory. Yes, I put the photograph up there only to make sure that people understood exactly what we're talking about. You know, you can say, well, I run the laboratory, and folks say, well, that's probably at the end of the hallway and you got a couple of benches there. We have 300,000 square feet of laboratory space. We have over 14,000 square feet of BSL-4 space. This is the spacesuit laboratory where you work on Ebola and Marburg and the most dangerous pathogens. We have nearly 30,000 square feet of BL-3 space and about 50,000 square feet of BL-2 space. So we have a complete portfolio of biocontainment resources available to us. We have some of the smartest folks in the world specifically working on what we traditionally call emerging diseases, those viruses that are often caused by, or those diseases caused by RNA viruses that are generally exotic. But when you talk about dengue or chikungunya or Mayaro or a whole bunch of other ones that you've never heard of before, these, in fact, we have the expertise right here in Texas to address those diseases. We also benefit from having the world reference collection for these pathogens. So when Zika became the disease du jour, we said, yeah, we've got that. In fact, we have the original 1947 isolate of it from the Uganda forest. So having that kind of resource right here in Texas available to scientists nationally and internationally is a tremendous resource for us. So we maintain an aggressive program in basic research, traditionally funded by NIH and other sponsors. We also have a second arm of product development. And our sweet spot is the test and evaluation of those promising products just before they go into human clinical trials. So we start with mice, and then we go on up the food chain until we feel very confident the product, whether it's a drug or a vaccine or a diagnostic assay, does what we anticipate it will do. And so you may have heard during the Ebola outbreak, the vaccine that was most successful had actually been developed, and most of the definitive work had actually been done right at our laboratory in Galveston. The diagnostic test, we had been doing diagnostics for a long time on this. Obviously, if you're doing a lot of animal experimentation, you get a lot of familiarity with telling when the virus is present, when it's not present. So one of the benefits of having that experience was early on in the Ebola outbreak, when we had these travelers that came back. Oh my God, you know, I was in West Africa, now I've got a fever, you know, what do we have? So we had Dr. Lakey can attest to this, we had a couple of specimens that came in, and while we didn't have a validated diagnostic test that FDA would approve, we nonetheless had great confidence in the assay, and we could say with some confidence that these people did not have Ebola, which at that time was an important step in the right direction. And we're at the same stage again now with Zika diagnostics. One of the benefits that we have is not only do we have a clinical hospital where we have actually just built a brand new hospital. If you haven't been there, you got to go look at it. It's unbelievable. But anyway, that's a sales pitch for another day. But as part of that, we're building a biocontainment laboratory so that we can actually manage, not laboratory, clinical facility, so that we can actually manage cases of Ebola, very similar to the facility that exists in Nebraska. We have 6 beds, they have 4. That's part of the Texas twist on it, I guess. But hopefully we will never fill all 6 of those, and hopefully we'll never fill any of them. But the capacity is there, and it's available. In addition to having that clinical capacity, the research capacity, we've also got an arm that is able to do high throughput diagnostic testing. So. And we exercised this during the recent H1N1 influenza outbreak. So we can process about 1,000 specimens in a 24-hour period with a diagnostic test that has been CLIA approved. So we're in the process of preparing that also for Zika. So overall, I think we have tremendous resources, and the important point here is that these are resources that exist right here in Texas. And importantly also, they're at an academic center. While there's 9 biocontainment laboratories in the States or in North America that have BSL-4 capability, there's only one that's functional on an academic campus, and that's ours. And I built a second one at the Boston University, but they continue to face hurdles in validating and getting full approval to handle select agents. We've been fully operational now since about 2008 or so, and we're humming right along. So anyway, it's a great resource right here, and I'm happy to be a part of it. So thank you.
Thank you. So our third speaker is a colleague of mine, Dr. Peter Hotez. He's a fellow for the Baker Institute in Disease and Poverty, but he has a lot of other hats and titles, including he's a professor and the dean of the National School of Tropical Medicine at Baylor College of Medicine. He's the president and director of the Sabine Vaccine Institute, which I hope he's also going to talk about a little bit today. He's an endowed chair in tropical pediatrics at the Texas Children's Hospital. And he's done a lot of work on neglected tropical diseases, which impact billions across the world, and especially those living in extreme poverty. And it's part of what he does at the Baker Institute as well. So,
thank you. First of all, I want to express my gratitude to CSIS and the Baker Institute for organizing this, and I'm particularly pleased to be with my fellow panelists here. We've been now making vaccines in the nonprofit sector for over a decade, and our mentors and teachers are all coming from Walter Reed Institute, and that's very deliberate, because we couldn't ask Merck or GlaxoSmithKline to teach us how to make a vaccine, right? So where do you go? So the only other place making vaccines in the nonprofit sector is the Army, and so all of our mentors are Army colonels and lieutenant colonels, and we wouldn't be existing without you. So thank you. And now we're trying to return the favor, where we're actually building vaccine development capacity in the Middle East, in Malaysia, in Brazil, and Mexico. So see one, do one, teach one, as they say. And also our other really important collaborators, the Galveston National Laboratory, because now we're making some biodefense vaccines, and how do you test to see if the vaccine works? And well, you need a facility like the Galveston National Laboratory, which is an extraordinary national treasure, and it's a real credit to Dr. Leduc, the way he's created that and built it up. It's your leadership, Jim, that's made that possible.
I had a little help.
You had help, but it still needs the vision and the leadership, and you provided that. What I want to do is give an overview of why I think this is not such a good news part of the story, why I think Texas is vulnerable and why Texas is an important global hotspot for the world's neglected and emerging infections, as important anywhere globally as you might think. Do I point? There we go. First of all, this is a recent analysis of a snapshot of where we're at with the world's neglected diseases in the Western Hemisphere. So when people think of neglected and emerging diseases, the first thing that always comes to mind is sub-Saharan Africa or maybe Southeast Asia. But there is this significant yet mostly hidden burden of neglected and emerging infections in the Western Hemisphere. And here's my best assessment of the numbers. The top two are worm infections, so there's a lot of worm infections, ascariasis, whipworm. Then comes dengue, which are incident cases, not prevalent cases, hookworm, Chagas disease, which you heard about, leishmaniasis, lymphatic filariasis. Now we can add Zika virus to the list, leishmaniasis, river blindness, and trachoma. And the overwhelming common denominator is these are mostly occurring among people who live in poverty. So it's not often appreciated that neglected and emerging infections are first and foremost diseases of poverty for reasons we'll discuss. And if there's right now, we estimate there's about 100 million people, 99 million people who live on less than $2 a day in the Western Hemisphere. And so these diseases are disproportionately occurring among that group. By the way, are there any people who live on less than $2 a day in the United States? So the University of Michigan has done a recent analysis. 1.65 million families in the U.S., around 5 million people live on less than $2 a day in the U.S. So that's part of the 99 million. And guess where most of them live? State of Texas. State of Texas has the largest number of people living in poverty. 5 million Texans live below the poverty line. So note to file, we're going to come back to that thought. So here are what I believe, now that we've sunsetted the Millennium Development Goals, as I mentioned before, I believe these are the new driving forces for the next wave of neglected and emerging infections. I still think poverty is dominant, poverty trumps all, but these other factors are now emerging of enormous importance. Deforestation, urbanization, human migrations, conflict and political destabilization, and climate change. And all of these forces belong to what some people are now calling the Anthropocene, which is a term that's being talked a lot about on college campuses. It was created by environmental scientists who noticed this rising certain chemical signatures appearing on the planet, like a lot of phosphorus and nitrogen because of fertilizer use, and radionuclides after the first bomb was detonated in Los Alamos, and the rise of CO2 and loss of animal species. And the idea is the end of the Holocene, which started at the Ice Age, is now happening in favor of this Anthropocene, where the first time humans are so profoundly manipulating the environment that it's really creating a new geologic epoch. And that coincides with the rise of what's replaced the Millennium Development Goals, which are the Sustainable Development Goals. And there's a lot of controversy about them because for the Millennium Development Goals, we had 3 of them were related to global health, and now for the Sustainable Development Goals, there's only one health goal. But we have a lot of things like the environment, water, conflict, peace, and these are all basically reflecting the Anthropocene forces as we're moving forward. So let's go through a few of these forces and see what's happening here in Texas. First is poverty, and this is a new analysis that we've done, and it's going to constitute a new book that I have coming out in a couple of months. And it's this concept that, and it's a little takes a little bit to explain. It's a little bit paradoxical. That is, most of the world's neglected and emerging infections now are not necessarily occurring in the world's most poorest, most devastated countries. It's actually they're mostly occurring in the 20 wealthiest economies, the G20 countries, together with Nigeria, that should be a G20 country because it is a bigger economy than the bottom 4 G20 countries, but it's not on the list. But if you look at the G20 countries together with Nigeria, they now account for half the world's helminth infections, most of the dengue, most of the Chagas disease, most of the leishmaniasis, most of the tuberculosis, most of the AIDS, most of the leprosy, most of our neglected and emerging infections. But it's the poor living among the wealthy that are accounting for these diseases. And so what I'm showing you is a new global heat map, and it basically looks at the areas of poverty where poverty and disease is concentrated in the world. So if you go into Brazil, you go into northeastern Brazil, that's where the poverty and disease is, including where Dr. Leduc worked way back when. If you go into China, it's not necessarily eastern China or going into Shanghai and Beijing, but going into Yunnan, Sichuan, Guizhou provinces in the west. And the same with northern India, northern Argentina and southern Mexico. So these are the world's hotspots of disease. So looking, for instance, northeastern Brazil, it's no surprise to me that that's the epicenter of the Zika outbreak, because northeastern Brazil has the largest concentration of poor people in the Western Hemisphere, and it's not only Zika that's occurring in places like Paraíba State and Pernambuco State and in Bahia, but it's also that's where the elephantiasis is in the Western Hemisphere. That's where the schistosomiasis is in the Western Hemisphere. And these are what the cities look like, and you can pretty easily see why somebody living under these conditions in Recife or Salvador da Bahia are going to get Zika virus infection. We now know that the 3 most important factors promoting Zika are 1, having the Aedes aegypti mosquito, 2nd, poverty, and the 3rd is crowding. So poverty, crowding, and the Aedes aegypti mosquitoes all congregate in northeastern Brazil. But that's not where they're restricted. Now where Zika is moving into Colombia, and the same thing, Aedes aegypti mosquitoes, poverty, and crowding. And guess what? Now it's moving into Haiti. So as we speak, pregnant women are getting infected in Haiti. So my prediction based on this is Haiti's going to be absolutely devastated by Zika virus infection. You have 250,000 babies born every year in Haiti. It's around, at any given time, around 200,000 pregnant women in Haiti, most of them living in poverty. If we know Zika is going to infect half to 2/3 of the population, we could be looking at 100,000 pregnant women in Haiti getting infected with Zika, potentially thousands of microcephaly cases. We're watching a humanitarian tragedy unfold before our eyes, but we won't see it for another 7 to 9 months. And this is the problem with this epidemic is by the time you recognize microcephaly cases, the horse has left the barn, right? It's too late to do anything about it. And that's why you have to be very aggressive at preventing it when it happens. So I'm very sad to see that the world is really doing nothing right now for Haiti, just watching this disaster ride out. And it is really a disaster because one of the things that we've learned about microcephaly, the microcephaly is the least of it. This is a virus that we know infects neural progenitor cells. It infects the stem cells that give rise to the fetal brain. So it's not just small head, it's small head and absent brain. So these babies are truly neurodevastated, not to mention all the babies born with more subtle defects. And it's happening now in a country in Haiti, like Haiti, which has no health system. So now the question then becomes, what about the United States? Does the United States have poverty? Well, this is before we before we look at places like Texas, let me just remind you where we are geographically, because there are other Anthropocene forces at work besides poverty. We're part of the Gulf of Mexico. All those arrows are showing all the communication between the Panama Canal and Houston. So as the Panama Canal doubles in size, Houston and Corpus Christi are poised to become the largest ports in the United States. So we have other forces like urbanization, human migrations, based on the geography. So we are here in Texas the perfect storm of Anthropocene forces that are going to give rise to neglected and emerging infections. We have the poverty, we have the vectors. You heard about Chagas disease this morning. We have the Aedes aegypti mosquito, and now we have the urbanization and human migrations. Other than that, it's a great place to live. So let's look at the current Zika risk maps. This is, we've seen some interesting Aedes aegypti maps out there. I think these are the best ones. This is where Aedes aegypti is concentrated on the Gulf Coast. And the reason we talk about Aedes aegypti is it feeds only on humans, except if there's a few non-human primates around. But it's a human, it's evolved to live in close proximity to humans. So here's the areas that are at risk. It's the coastal Texas, the Gulf Coast of Texas, Louisiana, and pretty much all of Florida. And now Simon Hay, it was at Oxford, now is at the Institute for Health Metrics, has used that and a few other factors to draw a Zika heat map, and you can see where our area is highly vulnerable. These maps only look at Aedes aegypti. They don't really look at poverty, but I like to point out that we have poor people here in our Gulf Coast cities. And coming from Washington, D.C. 5 years ago, I thought I knew what poverty looked like, but this is a different animal. The depth of poverty here in Houston along the Gulf Coast is, I think, like almost nowhere else in the United States. And this is what we look like. If you go into some of the historic wards of Houston, or into Aldine, where Congressman Green has part of his district, or into Sunnyside, this is not hard to find this. And those of you who've driven around Houston, you've all seen this. You've got houses with no window screens. You've got discarded tires filled with water, especially now after a lot of rain. You've got plastic containers. This looks like, this is mosquito heaven. This is Aedes aegypti heaven right here in terms of allowing the risk of Zika virus. So I think for all of those reasons, we're at high risk for Zika, just like Houston was the only major city in the last 15 years to experience a major dengue outbreak, which we had in 2003. We've got Chagas disease, we've got cysticercosis, we've got toxocariasis. So we are one of the global hotspots for the world's neglected and emerging infections. And as I thought about this, I suddenly had a flashback to a book that they made me read in junior high school, and I think I resented reading it at the time, just because I resented reading a lot of things in junior high school. But it came back to me, and I dug out a dog-eared copy of the book. And it was a book written in the 1960s by Michael Harrington, and helped launch Lyndon Johnson's War on Poverty subsequently. And the opening lines of the book are absolutely brilliant. It's a book called The Other America, and he says it so beautifully: to be sure, the other America is not impoverished in the same sense as those poor nations where millions cling to hunger as a defense against starvation. This country has escaped such extremes. That does not change the fact that the tens of millions of Americans are at this very moment maimed in body and spirit, existing at levels beneath those necessary for human decency. They are without adequate housing, education, and medical care. And here we are. So the total number of people in poverty hasn't changed, but maybe the percentage has gone down. But it's now become very concentrated on the Gulf Coast and in places like Texas. So we have the poverty, we have the human migrations, we have an important component of climate change, and now that's what our National School of Tropical Medicine is working to do. You know, we came down here because we wanted to be part of Texas Medical Center, getting enormous resources and scientific expertise to make our portfolio of vaccines, but we saw this also as an opportunity to do an active investigation on the problem of tropical diseases here in our state. So this is work by Christy Murray and Melissa Nolan Garcia, who've been aggressively trying to tease out this problem of autochthonous Chagas disease, transmission of Chagas disease within the state of Texas. And it's really incredible. One of the things they've done is identified all the people who went to donate blood and were told they had Chagas disease, and then when they see their primary care physician, they were then told, well, we don't, must be a false positive, we don't have that disease here, like we heard earlier this morning. And now we've tracked them down, and sure enough, they have Chagas heart disease, they have a lot of EKG changes, and so this is an emerging problem. We're finding it among hunters and campers. And so people ask me, is this a new disease, is it emerging? And I actually say, no, I actually don't think so. I think it's always been here, it's just that nobody cared to look. I think it's been around here a long time. Another one that not many people are aware of is this one called toxocariasis. It's a parasitic worm infection that's transmitted by stray dogs that are infected with the parasite. So if you go into the Fifth Ward or other poor neighborhoods in Houston, you'll see these packs of stray dogs. They're all teeming with worms, and they're shedding millions of worm eggs into the environment, and kids swallow them. These larvae have the ability to migrate through the brain and cause developmental delays. This is work shown at SUNY Downstate Medical Center. The CDC estimates 20% of African Americans living in poverty in the American South is infected with Toxocara. So if this is 20% of African Americans infected with Toxocara, and it's causing developmental delays, I wrote this provocative piece, as I always do, in JAMA Psychiatry called Neglected Infections of Poverty in the United States and Their Effects on the Brain, asking, is Toxocara among kids in the American South an important cause of the achievement gap noted among socioeconomically disadvantaged kids? And the answer is, well, we don't know. And what's really interesting is how many NIH grants are given out for Toxocara. Anybody want to guess? That's right, 0. We applied, we got turned down, but I think we're going to go back in. But there's 0. But so this is a real example of a neglected disease. You know, as important as Ebola is, you know, to the American population, we had 3 cases. Here we have 20% of African Americans living in poverty may be affected by toxocariasis, and we have 0 awareness and 0 funding. So this is a lot of the disease that we have here along the Gulf Coast that needs to be better highlighted. So what we're trying to do is now make the next generation of vaccines for a lot of these diseases. It's hard slogging because they're tough scientific targets, and they're often diseases that people don't necessarily appreciate our problem. So we have a interesting vaccine development facility called the Sabin Vaccine Institute and Texas Children's Hospital Center for Vaccine Development, or as my kids call it, Dad's Guaranteed Money Losing Company, that we're making these lists of vaccines in various stages of clinical trials. So during the discussion, I think we'll have time to talk about that in more detail. So that's kind of an overview of where I see things right now.
Thank you so much, and I want to bring up the fact that actually, since you brought up Zika and talked about that we made copies of one of our policy briefs. I think they're on most of the tables that relates to Zika. It's something produced by the Baker Institute with the center with Dr. Hotez. And bringing that in with our first question, I'm actually kind of curious. It seems like Zika happened and we were kind of a little surprised. We were surprised by the impact it had on the health, especially of developing children. We were surprised how it transmitted, finding out later that it was actually transmitted. A year ago, Ebola, we were surprised. We had some research in the pipeline, but never actually seemed to complete on a vaccine. And I was actually kind of curious for each of your perspectives on what you think went wrong or is going wrong, and what you think we could actually do to kind of be more successful in the future, kind of as far as our research and development to kind of respond to these emerging infections, or thinking about doing.
Ladies first.
Okay, so I'll tackle that a little. So what went wrong? Well, it's hard to say. I think it was a perfect storm. Mm-hmm. If you want to talk Zika first or Ebola first, you didn't address it. Okay, so I'll talk about Zika a little bit. So this ties into a little bit about how we do our prioritization. Every 3 to 5 years, we take a look at what are the infectious disease threats to our service members. And we gather a community of infectious disease experts and programmers and researchers and put them in a room, confined, and they work through these issues. What are the problems? And so we just redid our prioritization last August, and surprisingly, Zika came on the list, and it was fairly high on the prioritization list as a risk to the DoD. We have active, ongoing biosurveillance activities across the globe, and they were picking up these signals early, not understanding the true impact on health and neurologic disorders at the time, but certainly it was a trigger that there's going to be an issue. And so Zika actually ended up on our prioritization list. However, although it was on the prioritization list, it's a long list, and the funding is short. So our programs are heavily involved in malaria, HIV, diarrheal diseases. Our focus is on what is the operational impact, so to the service member in terms of, it's measured in lost duty days. So what diseases actually take them out of the fight for periods of time. So in terms of Zika, it fell on that list fairly low because there wasn't a great understanding of what that impact could be. And, it was thought to be very low impact on service members and compared to some of the other diseases. However, we have a long history of research in flavivirus, dating back to Walter Reed and yellow fever and development of the yellow fever vaccine. So we kind of tie back to the need and the importance of having infrastructure and capacity. We were able to leverage the capabilities that we have and the competencies in flavivirus research, and are currently in partnership with HHS, BARDA, and NIH developing a vaccine for Zika. It's projected to hopefully be first in humans in October. It's a partially inactivated vaccine. And we're doing this in parallel with some other efforts as well. There's some other vaccine efforts. So while we're caught off guard, I agree, and there's some missteps along the way. I think each time we learn something new. So going back to Ebola, I think that was a good situation for us because we already had a funded program in Ebola, and it's been going on for decades. We were able to quickly leverage that program in response. We had a team in early spring when the outbreak first was recognized. Who was there doing Lassa research, and it was just surveillance, building capacity in Sierra Leone for diagnostics for Lassa. And all of a sudden they're like, hold on, we're picking up Ebola in Liberia, and they quickly shifted focus and sent that capability over to Liberia, and that laboratory is now, it grew. It was a partnership with NIH and Ministry of Health of Liberia and USAMRIID, our laboratory, and grew in capability. So they were doing diagnostics for Lassa, and they now have sequence capability now to track the evolution of the virus. That just was handed off to the Liberians back to the Ministry of Health, and they're fully staffing that and operating. So that's what I'm talking about in terms of capacity building. I think we had an opportunity based on where we were, and we had a capability that had been grown, but it had been grown over decades. Mm-hmm. You can't fly a plane in flight, so you have to put a plane together in flight, sorry. So you have to think about what can we do now to be able to leverage in the future, and not what can we do alone. What can we do as a collective group? There's certainly areas, the basic researchers, the applied research, the vaccine, the manufacturers. I think as a collective group, we have to get together and figure out how we, as pieces of a puzzle, put it all together for the collective good. So, thank you.
Mm-hmm. Let me just add a couple of comments about Ebola specifically. And the question was, why wasn't a vaccine available when it was needed? Well, as of the end of March of this year, there had been 28,646 cases of Ebola, 11,323 deaths. This is based on WHO's numbers. No one had ever anticipated that there would be this kind of tragedy. And these numbers could have been much, much worse had Nigeria not aggressively controlled the introductions when they occurred. So I think the entire scientific and public health community was really caught off guard. As you heard, DOD has been interested in Ebola for a long time, and that's because that was potentially weaponized by the Russians back in the bad old days. There was an aggressive program to develop filoviruses as an offensive weapon. So there was this foundation of scientific interest and product development that was well established, but the only funder has always been the U.S. government or other governments in other countries. There's never been any concern that this would be a commercially viable market. And there's been different needs, quote unquote, defined so that as products were developed, there were different products under consideration and under development. So there was really not a critical path defined with clear-cut benchmarks that if you were going to make a vaccine, all right, this is what we want, this is how we're going to do it. It was kind of a diverse approach. And part of that challenge is because this was a very, very difficult technical problem to overcome, complicated by the fact that this virus will kill you very easily, and so you need appropriate conditions to work on it. So I don't want to in the least diminish the significance of the technical problem itself. The other thing is we as a nation and we as a global public health community hadn't really thought about how you take a promising product and evaluate it in a least developed country where there really is no infrastructure. And certainly during the peak of the Ebola outbreak, when there had just been a devastating impact on the entire clinical care community of West Africa, it was worse than starting from ground zero because there was all of this tragedy and destruction underway. So that was a real problem. How to go forward? I think what we need is long-term sustainable collaborations on site. And I emphasize the sustainable part. It's nice to come in to develop capacity, but unless you're there for the long haul and working in true partnership, I think that these efforts are doomed to failure, and we've seen them time and time again. The last point I'd like to make is I was pleased to hear CDC's comments about the collaborations with the global health security agenda. It's becoming increasingly apparent to me and many others that the interface between global health and security is really quite a robust interface, and we actually need to be paying a lot more attention to that. So perhaps this is a mechanism where we can not only establish capabilities, but sustain them over the long run. Thanks.
Well, thanks. I agree with all the comments. I'll make a few add-ons. One of the things that the Ebola vaccine taught us is that we have a market failure and a broken business model for how we develop neglected disease products. Let's review what happened. So Tim Geisbard and Gary Nabel published on the Ebola vaccines back in 2003. The technology sat there for a decade with making incremental improvements, but largely undeveloped because there was no financial market. The big pharmaceutical companies weren't interested. The U.S. government, through BARDA, the Biomedical Advanced Research Development Authority, then when things got really ugly in West Africa and things were looking dire, in 2014 they put up $100 million. Then GlaxoSmithKline licensed the technology. Then Merck licensed the technology. Grissel licensed the technology. They turned it around into a bottle of vaccine in record time. And by the time clinical testing was underway, Ebola was gone and 11,000 people had perished. So I think part of the problem is we are the big pharmaceutical companies do some great things, and I'm actually a big admirer of the big pharmaceutical companies, but we cannot rely on them exclusively for making our products. We need additional actors. And that's what we're trying to do at Sabin Vaccine Institute and Texas Children's, is see if it's possible to build vaccines, not just make technology to license to a big pharma company, but build vaccines, doing the manufacturing, the process development, the regulatory filings, the quality control, quality assurance, the lot release, the stability testing, all of those things that a pharmaceutical company would do, but do it in the nonprofit sector. We don't know what the end game looks like. So far, we've gotten very good at going all the way through to phase 1 clinical trials. But now we're going to have to figure out how we're going to do advanced clinical trials and industrial scale manufacturing. So the exciting thing is there's no roadmap for this. The terrifying thing is there's no roadmap for this. And so we'll continue to report on progress. I think the other component to your question about why the world was caught off guard by Zika, actually Galveston National Laboratory wasn't. They had Zika. In fact, they became the resource for all the Zika virus. I think what took everybody by surprise was the microcephaly, the explosion in microcephaly cases. I think the world has responded pretty quickly. There's been great Brazilian science done on this. I think the big problem that I see now is the total absence of political will to do anything about it. People forget that 18 Latin American countries eradicated the Aedes aegypti mosquitoes between 1947 and 1962. It wasn't easy. It's hard. Getting after Aedes aegypti mosquitoes is hard work. It's house-to-house environmental cleanup, getting rid of the tires, providing window screens, and you can do spraying, sometimes indoor spraying. People don't necessarily like it when the guy knocks on your door and says, we're here to eradicate your Aedes aegypti mosquitoes, but it is doable, and it has been done. We're not seeing any political will internationally to do this, and I don't know if we're going to have what it takes to do it here on the Gulf Coast if we start seeing Zika transmission. We've historically refused to control Aedes aegypti mosquitoes on the Gulf Coast. We've never done it, to the point where during the 60s, the Latin American countries were publicly complaining that we were getting reinfested from our Gulf Coast mosquitoes. How different is that compared to our recent debates that we've been hearing about? So we'll have to see.
Okay, so we're actually running kind of short on time, but I want to see if we can actually get one question or two from the audience really quick. I think there's a gentleman over.
Thank you very much, and this is a great discussion. On the vaccine piece, and I think we have some 3 panelists who are all doing a lot in terms of developing the vaccines, but just moving forward, assuming these vaccines are developed and we manufacture, what is required from a policy and operational point of view to make sure it's actually delivered to the people that need to receive them?
Right.
Well, for the Zika vaccine is going to be a problem. I think we're going to move pretty quickly to first-in-human studies, phase 1 trials for safety. I think that'll move pretty quickly. The problem's going to be, there's going to be 2 problems from a regulatory perspective that may prevent us from having a Zika vaccine in the near future. One is the regulatory hurdles for who the target product profile is. You know, when you're trying to do safety testing, the lowest bar are healthy adult volunteers. A higher bar is step-down studies in children. What's the highest bar of all? Women who are pregnant or thinking of becoming pregnant. Who do we want to use? Who needs this vaccine? Women who are pregnant or thinking of becoming pregnant. That's a problem. I think the other one that's going to slow us down a lot is the fact that this virus is associated with a pretty serious Guillain-Barré syndrome. So I'm guessing that the FDA is going to require some pretty large-scale tests to prove that we're not causing Guillain-Barré through the vaccine, and that both those things are going to slow us down quite a bit, I think.
It looks like we actually hit our time. I'm so sorry, but our panelists are going to be here all afternoon, so if you can grab them at lunch and they can answer some of your specific questions. But I just want to thank my panel for their time. Thank you.
Thank you.